So I've been in this community for more than 10 years, and about 4 years ago, I became part of UCLA here when UCLA opened the oncology office here. And one of the main reasons was because we have trials available, So my background is molecular biology, so I've always been interested in what really makes the cancer happen, what drives the cancer, what really happens at a molecular level with the cancer. And that's why that's where now the oncology is going, and it's really an exciting time because we are understanding more and more about cancer as to what's driving the cancer, and it really designing treatments based on that. And that's where most of the new developments in cancer are happening, and that's where most of the new developments will continue to happen. And one of the important work that UCLA and many other institutions are doing, they have translational research as their basis for the oncology research. What they're trying to do is get as much molecular information on pieces of tumors as they can collect, and they have detailed information about the gene profile of the tumors at the molecular level, so they can figure out how many different kinds of tumors are being driven by different kinds of molecular defects and what kind of drugs can be designed against them, and therefore helping in develop different targeted drugs and different kinds of more specific drugs different than chemotherapies. And since I have a molecular biology background, I was very interested in that, and that was part of the reason I became part of the UCLA research program here. We have some of the trials available locally, but then there are other trials we don't have available locally just because they are available to a limited number of patients, or they're earlier phase trials which require a lot of specimen collection and other things that we cannot send from here down to the campus, and those trials are then opened only at the campus, but we can screen out and select patients for different trials. Anyway, so let's talk about lung cancer in general. Most of these slides are provided by my two associates at UCLA who do lung cancer, Dr. Goldman and Dr. Giron, so I'd like to thank them. Okay. So lung cancer is actually a very common cancer. Every year, more than 200,000 patients are diagnosed with lung cancer. So it's one of the most common cancer that we see. And in terms of the smoking, it's been one of the most linked cancer in terms of smoking. Every cancer patient always asks me, what is the reason for my cancer? And for the most part, we cannot really link a reason for the cancer, and that's true for majority of the cancers. But majority of lung cancers do happen in smokers, although 15% of lung cancers do happen in non-smokers also. So significant number of smokers will develop lung cancer in their lifetime and may die of lung cancer. One exciting part of all this information is that for the first time in last several years, the incidence of lung cancer actually went down after a steady increase of lung cancer over many, many decades. And I think that has to do with the decline of smoking that happened some time ago. Now, finally, we are seeing that the incidence of lung cancer is beginning to drop. So 85% of the lung cancer that we see happens in smokers, and overall, both the incidence and the deaths from the lung cancers are declining, but most of it is from smoking being cut down, not as much from the treatment, but definitely there are improvements in the treatment also. So this slide basically tells you the incidence of different kind of cancers in men and women, and you can see that the most common cancer in men is prostate cancer, and the most common cancer in women is breast cancer, but the most common cancer cause of death in both men and women is actually lung cancer. And we are now beginning to do some trials with different targeted drugs for small cell lung cancer also. That's a new field. And interesting part of some of the trials that are being done in small cell lung cancer have to do with the PARP agents. The PARP agents are actually drugs being also tested in BRCA-related breast and ovarian cancer. So you can see straight up that many of the drug treatments that are being tested, their testing is derived from what is being expressed in the tumor, not where the tumor is coming from. So PARP agents are being tested for ovarian cancer and breast cancer of certain patients, but they seem to be also effective in some of the small cell lung cancer. So that's another exciting field of development in small cell lung cancer, and also other targeted drugs and immune therapies are beginning to be tested in small cell lung cancer also. We are a little bit behind in the small cell lung cancer. It's not as common as lung cancer as the other ones, but eventually this should catch up also as more trials get opened in them also. All right, so let's talk about non-small cell lung cancer. So when somebody says you are really lucky and the patient got diagnosed as a single spot, and this is very lucky that we have found it so early, even stage 1 lung cancer has a 30% chance of coming back. So those incidental finding of lung cancer that surgeon can take out and clear it, even those have a pretty high risk of cancer coming back. But most of this, we do know with every cancer, including lung cancer, that if we diagnose cancer at an early stage, the outcome is better. And because of that, in smokers, there have been a lot of studies to see if they can detect cancer early, and even patients who used to smoke and have quit smoking within last 15 years. And those high-risk patients, if they've had sufficient history of smoking, like 30 packs a year they call about, and they stopped smoking in less than 15 years, those patients are now being recommended to have screening CAT scan with a low-dose CT, and those can diagnose sometime cancers in an early stage. Chest X-ray is never been found to find cancer early enough by screening, to use chest X-ray for screening. It's a simpler test, it's less costly, but lung cancer screening by chest X-ray has never been found to be very effective. So if somebody is going to be screened for lung cancer because they have a smoking history, it has to be by CAT scan, not by the chest X-ray. So if the lung cancer is found early, most of the treatment is surgery, and in the case of non-small cell lung cancer, and many of the stage 2 as well as most of the stage 3 lung cancer patients, even if one can operate on them, they still need chemotherapy usually. So we're going to go to more advanced stage lung cancer. So we talked about limited stage surgery, sometimes radiation. If the patient is not a candidate for surgery, more and more so we can do limited radiation. If we don't think patients' lungs can handle a bigger field of radiation, then radiosurgery, which is more like radiation just cutting off the tumor, those kind of modalities are also an option for those patients who are not candidate for bigger surgeries. All right, so if the cancer is found in stage 2 and 3 and the surgeon is able to clear it surgically, we still recommend chemotherapy. There were many studies done all over the world actually, and many different drugs were used and different protocols were used and different stages of cancer were used, and all of them showed benefit with the chemotherapy, and usually it's a short duration of chemotherapy. It's only 4 cycles, and this data doesn't look very impressive. I mean, you see that the curve goes from here to here overall in terms of the lung cancer, but there was a definite benefit. But many of these studies were done before we understood a little bit more about what drugs work for lung cancer, and hopefully as we get better drugs, we can improve on this data. But at this point, most of the stage 2 and stage 3 lung cancer patients, even when the cancer are completely resected, are recommended 4 cycles of chemo because they have a pretty high risk of cancer coming back. All right, so what is stage 3 lung cancer? As you can see, if there is a cancer, then we look at which lymph nodes that it may be involving. If only these lymph nodes are involved, we call it stage 3A. These patients are still thought to be possibly resectable. Any lung cancer we see in newly patient and has a diagnosis, as part of the staging, we want to see, is the tumor resectable? Can we operate on the tumor and remove it? The second part of the algorithm is the patient operable? Because when you remove these cancers, you may need to remove a pretty large chunk of lung, so we need to see how the patient can tolerate breathing-wise losing all that part of lung. We also have to look at how their heart and other things can tolerate such big surgeries. But if both of those things look like the patient is operable and the tumor is operable, then after the surgery is done, and as long as these central green lymph nodes don't have any cancer, then the patient will have the surgery and will get chemotherapy afterwards. But if there are lymph nodes involved in this central area, then that upstages the cancer from 3A to 3B. And once the cancer goes to 3B, We do not think we can control that cancer by surgery, so surgery is not an option in those patients, and those are treated by chemoradiation and not by the surgery. So as you can see from my talk so far, we've been talking chemo, chemo, and chemo, and those are not the new directions. Those are the old directions that we've been working with cancer. But the reality in cancer is that in any cancer, when we develop new drugs, new ways of treating cancer, first we try out those treatments in advanced stage cancer in patients who may not have other good options. And once we find those drugs or those treatments to be effective in those advanced stage cancers, then we gradually shift those drugs and test them out in earlier stage cancer so we can cure more patients. That's how all the drugs are developed in all the cancers. So we will go through them gradually. So those were basically mostly we were talking about the old-fashioned chemotherapy, and the chemo may be done before the surgery or after the surgery. When the chemo or radiation are done before the surgery, those are called neoadjuvant. When we do the treatment after the surgery, we call that adjuvant treatment. But these patients will get some kind of treatment before or after the surgery. But these are all still up stage 3. We're not gone on to stage 4 yet. Okay. All right. So what is stage 4? Stage 4 means that more than one spot is present in the lung, or the cancer went around the lung into the lining around the lung or around the heart, or it went to other organs. It went to the liver, it went to adrenal gland, it went to bones or brain or any part of the body. But even when it is limited to the chest, if there is more than one tumor in the lungs and that you cannot remove it altogether, and it is in the lining of the lung, we actually call it stage 4, not just even though it's limited to the lung and the surroundings of the lung. And you can see the old studies when we had the old chemotherapy, first thing was to why treat patients with advanced cancer? Well, there were, even with the old drugs, a lot of studies showing that comparing supportive care, meaning just trying to keep patient comfortable, treating the infection, treating the symptom, versus actually giving them chemotherapy on top of supportive care, patients lived longer going from not getting any chemotherapy to chemotherapy. And some of these trials were even done in England and Europe, where they're more conservative about treating advanced cancer. And even there, it showed that actually patient benefited from getting chemotherapy in advanced stage cancer. So let's talk about what's new going on in lung cancer, and some of them is not very new. Even in terms of chemotherapies, a few years ago we found out the drug pemetrexed, which is not studied in any of the studies we talked about showing survival benefit. These drugs, this is a newer drug relatively. It's not that new, but it's not been out more than, I think it's been definitely out less than 10 years. It's pretty well tolerated drug. We know it is a better chemotherapy for adenoCA of the lung. So we use it early in the adenoCA of the lung. Its other name for it is Alimta, if any of you have always ever had it. We do not use this drug in squamous cell lung cancer. It does not work in squamous cell lung cancer. So knowing, it's important not just to make a diagnosis of cancer, it's also important to know what kind of lung cancer, because the drug, even the chemotherapies are decided based on that, not only our targeted drugs. What is bevacizumab? We will be talking a little bit more about it. The other name for it is Avastin. It is used along with chemotherapy early on in lung cancer, in most of the lung cancer, except in squamous cell. If the squamous cell cancer, we do not use it because the tumor can bleed in itself, and one of the way these drugs work, it affects the blood vessels. So the risk of this drug is it can cause bleeding. So if there is squamous cell, we do not use it. For non-squamous lung cancer, we do use it. Again, these drugs are used in cancers other than lung cancers also. And another important concept has been maintenance treatment. So it's not just doing 4 to 6 cycles of chemo and stopping the treatment. With certain of these drugs, one can keep patients on these drugs for years and years as long as they're working. So Alimta and Avastin, this drug and this drug, if the drug is working, the old concept in lung cancer was give 4 to 6 cycles even if the drugs are working and then stop it. But with some of these drugs, because the side effects of these drugs do not build up over time, you can keep patients on these drugs for long periods of time, and they're very well tolerated. I even have an ovarian cancer patient who is on Alimta and Avastin for 4 years with good stable disease. So these are very well tolerated drugs. Okay. So doing a maintenance became a new concept, and also sometimes we switch drugs, meaning we do 4 to 6 cycles of one drug and then switch to another drug and do maintenance with that. So chemotherapy has been still the standard of care, but we're trying to move away from it and use more drugs which are more effective in the specific kind of lung cancers and have less side effects. Okay, so we're going to start off with this. And this kind of also explains a basic concept in cancer. There are growth factors that the tumors can produce, which in this case it is VEGF, and these growth factors then stimulate the tumor to grow blood vessel. There is a concept of what we call angiogenesis switch. So the tumor can be sitting dormant for a long period of time, and then somehow it changes mode and it starts making a lot of VEGF, and then it starts growing a lot of blood vessels, and in a way it develops a blood supply for itself and it tries to feed itself. So that's the reason then tumor tries to grow uncontrollably. And we do see that with many tumor. So Avastin or bevacizumab, which was one of the drug I talked about, that is a drug that basically attacks these target drugs here, these VEGF. It zaps up the VEGF, so it keeps the tumor from growing blood vessel. So that's been one of the older concepts that we have been trying to use drugs other than chemotherapy. And the Avastin is used for lung cancer. It is also used for colon cancer and also used for some other cancers also. So basically, one of the ways to target this is either target the blood vessel that compounds itself, the ligand, the stimulant there, which is the VEGF in this case, or wherever the VEGF is binding on the cell surface, and I'll go to the next slide which will make it clearer, you make an antibody so the VEGF cannot bind there. So you can attack the same pathway by different ways. So how I can explain it better? So this actually goes in a reverse sequence. Let's go a different way. Okay, let's start with this. The same concept can apply to many different forms of targeted drugs we can use. So the cells usually have some receptors, okay? And then the growth factors of different kinds can bind to these receptors, and then that turns on a series of chemical reactions which go from the receptor all the way down to the nucleus, which makes the cell grow rapidly. Okay, and the same mechanism apply about then that causing to develop blood vessels and making the cancer survive and not die, and making the cells divide and grow and spread out. And that's the basic concept for most of the cancer. So most of the targeted drugs are being developed in many different ways. You can develop something that will take away these stimulant or growth factors. You can develop something that will block this thing. Or you can develop some small molecules which get into the cells and block it here, block it during the whole cascade of chemical reaction, or go even inside the nucleus and block it. So those are all different ways targeted drugs can stop the cancer without them being like chemotherapy drugs, without them killing the healthy cells. So really turning off what is going on in there. I'll go backward here. So that's one concept. Find out what is stimulating the cancer and try to block that. So when we go back to the slide before this one, so Avastin is the drug which is attacking here. Cetuximab, which is an antibody used for colon cancer right now, but it's being tested now in lung cancer also. It blocks the receptor where the growth factor was binding. So we are overlapping. Cetuximab is used for head and neck cancer also. So a lot of these different ways of treating is going across different cancers basically. So, and the other way is to try to figure out what is going on that particular tumor. What are the gene pathways? Think of it as a subway. Okay, you have different trains going on. So you have different stations and different trains are going on. What is the main train going through and where we can block that train for the cancer to develop? Okay, so you figure out you analyze the tumor, you figure out what are the mutations those are driving those cancers, and then use the drugs that will turn off those mutations. And there are many different mechanisms where the tumors grow, even in lung cancer, even adenocarcinoma of lung cancer. Different tumors are being stimulated by different mechanisms, so you need to analyze the tumor, and the same drug will not work for all different cancers, even all different lung cancers. Although the same drug may work with different kind of cancers, meaning it may work for lung cancer, it may work for colon cancer, it may work for breast cancer, but it may not work for all lung cancer, it may not work for all breast cancer. So we need to analyze the tumor, what is stimulating, what is the driving force in that tumor, more so than what is the type of cancer this is in this situation. So there are certain markers for which we already we have targeted drugs for these. EGFR was the first target. We talked about how cetuximab may be used at the antibody level, but EGFR, the small molecule for that is Tarceva or ilatinib, and that was developed a while ago, and that is used for treating early stage or even advanced stage adenocarcinoma of lung. We do see them more often in non-smokers. We do see them more often in women. We do see them more often in Asian origin patients, but they do work in smokers, they do work in men, and they do work in, but the tumor mutation has to be present. Otherwise, those kind of drugs which target that will not work. Similarly, we have targeted drug for Alch mutation. I'm using brand name, which I'm not supposed to use, but the drug names are much more harder to pronounce. The crizotinib is a drug that is used for the Alch mutation. So the tumor has to be analyzed for the mutation and then use the right drug. Then there is another mutation, ROS1. We found out that the same drug which is used for the Alch mutation actually works for ROS1 mutation. One of my family members recently got diagnosed with adenocarcinoma lung with 15 mets in the brain at the same time, and Dr. Goldman, she had this mutation, and we were able to get her the drug, and everything, she has no side effect, and all the tumors are melting away. So analyzing the tumor, and first she was analyzed for these two, and she didn't have either one of those. So I was very disappointed that, doesn't look good. Then we analyzed the other mutation, and she had this mutation, so we were able to use the drug. So it's very important to get enough tissue to analyze tumor. I know the biopsies are very many times difficult in lung cancers, and sometimes involves invasive procedure, but it is very important to not just make a diagnosis of cancer. It is important to know which kind of cancer, and if possible have tissue to analyze for these mutations. The tests are becoming better and better where they can do the analysis with small amount of tumor cells and not having big pieces of tumor. But if we do multiple analysis at the same time, we have a better chance of finding these mutations. If we do sequential, then the tissue runs out and we can't test the tumor for it. So I'm going to go on to some other mutations. So there are many other targets that are being looked at that we have small molecules for, that we are testing to see if we can use them in those lung cancer which may have mutations related to that. And also these molecules are being tested in other cancers which may have similar mutations. So we went over this. This is the basic concept. So you can develop a drug to take away the growth factor. You can block the binding of the growth factor. You can somehow do that the receptor cannot transmit the signal inside. And then I will go in further slides how there's a cascade of chemical reactions that may be going on, going from the surface all the way to the nucleus to make the cell grow. You can cut off that pathway along that train at any of those stations or multiple stations. Okay, this is not to really understand what Alch mutation does and how that developed, but more to understand this. Only 4% of these cancers will have these mutations. So that's why it is very important to analyze the tumor and test the right drug on the right patient. You can imagine if it is present in only in 4%, and we test this drug in all lung cancer patients, guess what? The drug will look like it's not effective drug. But if you only pick up those 4% patients who have the mutation, give them the right drug, you will have a very effective drug. So that's why it's not, when we have trials and that tumor does not have that mutation that we are testing that drug, it's not because we want to keep that drug away from you, it's because the drug has no chance of working in that tumor. So we have to use the right drug for the right tumor. Okay. All right. So this is with the Alch mutation. So this patient had the mutation, got the drug, and you can see the tumors literally. With many of these targeted drugs, the response is very, very quick, literally in weeks' time that the tumors basically disappear. And we don't need to go through that. It has a series of patient information as to how those responded on the treatment. Okay, so tumor analysis. So we are beginning to analyze more and more different kind of gene mutation in different tumors. So we have drug for this, we have drug for this, we have drug coming out for this pretty soon also that it seems to be, and then a lot of different targeted drugs are being tested for a lot of these mutations. And the tumors may have more than one mutation, so many times if one kind of mutation drug stops working, then one can also go to another drug against another target. Or we try to understand what is making that tumor resistant to that drug, and then try to attack the mechanism of resistance. So at this point, we know that more than half of the lung cancer have mutations that we know about. And over time, we will try to understand more of these mutations and have more targeted drugs develop. This is just a complicated whole bunch of names in there. But this is to explain that at the molecular level, what happens in the cancer is fairly complex. And that's one way to look at it. Another way of, sorry. Where did I go? Another way to look at it is that it gives us as many targets to attack. So we try to figure out in that particular tumor what all mutations are working, so what drugs we can use and what combination of drugs may be working. In many studies that we do with the tumors, we ask for a tissue before, and then if the patient is on a study drug, many times we ask for a tissue sample later on. And for a lot of patients, that's not something very pleasant. The reason we do that is we want to see what is changing in the tumor when exposed to the drug, okay? What is going on at the molecular level in the tumor, so that we can know what is changing and what new targets we need to attack, because we know the drug will stop working and we need to be ready to attack it with the different drugs. So by testing the tumors on certain drugs, it's the only way we can figure out what are the mechanism of resistance to the drugs and what combination of drugs we need to use eventually to really find a response in the patient so that we don't develop resistance to these drugs. So for example, this is a patient who had the EGFR mutation and got the targeted drug for that. And this was the CAT scan before. After the drug, all the tumors disappeared, but subsequently tumors start growing again. So that's not uncommon with many of these targeted drugs. Patients have great responses, but after some period of time, these drugs stop working. That's because, unfortunately, tumor cells are smart. We block one subway line, it starts using different subway lines. And that's why we need to analyze to see what are the different pathways cancer start using when we try to block one subway line, so that we use a combination of drugs or we switch to the other drug to deal with the resistance of the tumor so we can have the response again. Okay, so these are some of the different targets for which many different trials are being conducted both at UCLA and many other areas. These are more considered targeted drug. What does targeted drug means? Meaning it targeting a specific mutation or specific pathway, as opposed to chemotherapy, which may be killing, just killing cells. This is to turn off. Some of the targeted drugs don't even kill the cells. It just turns it off so the cancer cell dies by itself. Normally, when the cells get damaged or become defective, body cells have a way, the term uses apoptosis, which means if the cell has been damaged significantly, the cell will die. But the cancer cells have a way to survive even when the cell has been damaged significantly. And these things allow the cancer cells to die without killing the cells around it. Okay. So this is one of the drugs that is being tested for the KRAS mutation in the lung cancer, and the data is looking promising. This is a different concept now. I'm going to talk not about the target drug, but more about the immune therapy. And all the immune therapies, and actually a lot of new exciting T-cell mediated immune therapies are finally becoming very exciting, not just for the lung cancer, but for many cancer. And actually some of the other exciting data is coming for acute leukemias also, which especially in the children, ALL, a lot of very exciting data is coming. The T-cells normally recognize something on the abnormal cells, so that maybe a viral antigen, maybe any cell which is defective, and it has a receptor and it recognizes there is something off there and it binds it, and then the T cell will, through the immune mechanism, will kill the tumor cell or the bad cell. There are a lot of lung cancers, but also many of the other cancers, they develop or they express something called PD-1, and that literally gives that's literally a tumor cell giving a finger to Dr. Glaspie described it as giving a finger, meaning it keeps the T cell away from the tumor. So it keeps the tumor cell not being recognized by the T cell, and the T cell cannot, T cell is a lymphocyte, immune part of your body. So it keeps your immune system for killing the tumor cells. So now there has been working on antibodies which will either bind this ligand itself, the PD-L1, or they will bind to the receptor of this PD-L1 or PD-1, and either way these antibodies will then allow the T cell to attack the tumor cell. Okay, so we are trying to train the patient's own immune system to recognize the tumor cell and then attack the tumor cells. And that's part of the reason when we look at the mechanism why these drugs are not specific to one cancer. So PD-1 and PD-L1 drugs are being tested for the appropriate cancer, not just for the lung cancer, but melanoma and many other cancers. So we will find that these drugs do cross the boundaries in terms of the type of the cancer, but we have to design them for what is that tumor is expressing. And if the tumor is not expressing those specific mechanisms, then we have to go on to different mechanisms. So this is some of the data on one of the PD-L1 targeted drug showing that how it works and how it is showing the response. But these drugs are still in development, and the results are promising, but they are not available yet outside of the trials. All right. So we always have, I was just showing to one of the gentlemen here, we always have a series of these were, I just printed from my email that we have the different lung cancer trials we have available right now. These, I'm not going to go through the trials because these things keep changing every week. New trials keep opening, new trials keep closing. Some of those trials we have available locally, some of those trials we don't have available locally, and patients have to go to UCLA. Many of the trials may be available at other centers also, City of Hope or USC also, but there's a lot of exciting work going on because now we understand what's driving different kind of cancers. For many of these different targets also that we talked about, we had initial target drug, what we call class 1. Now what is being developed is class 2 and class 3, so that even if the class 1 drugs stop working, we can use more effective drugs, which can bypass those resistance and still get a response. So a lot of new exciting developments are going on, but it is very important to have a piece of tissue to really analyze, so we use the right drug in the right patient. Okay. Questions?
Can you do the test using the fluid, or do you have to have the tissue?
Need the tissue, but it can be sometimes fine needle aspiration also if it has enough cells. Fine needle aspiration is which has cells, but it is an aspirate basically. But if there is not enough cells, they cannot analyze. I didn't go over everything in the lung cancer. We are even using, and it is actually approved also, we are using anti-estrogen in combination with targeted drug in some of the women with breast cancer, some of the women with lung cancer. So you think of anti-estrogen as drugs for breast cancer, but they are being used for lung cancer also, and actually are approved for certain lung cancer, but they can be only used in women. Then HER2/neu, which is again Herceptin. Herceptin has been used for HER2 positive breast cancer. Now there are certain lung cancer which express those markers. We know gastric cancer, some of the gastric cancers express HER2, and that's not specific to male or the females. Again, you need to analyze the tumor. The more tissue we have, a better analysis can be done as to which drugs may become effective and may be used in those patients.
Did someone have to wait until they've gone through so many treatments of chemo before they'll do the trial?
No. Depending on the drugs, there are enough. We have certain trials which are only open first line, meaning the patient is diagnosed and has gone through no chemotherapy. Then there are second line, third line, so we have trials at every line basically. The earlier you get, these trials keep changing, but the earlier you're evaluated, the better the options, because say you have received a certain chemotherapy. With many of these trials, you have a standard arm. If you have gotten all the standard arms drugs, then you cannot use certain trials. So if somebody is going to be considered, we have one trial, for example, it's called heat shock protein. Well, the standard arm for that is Taxotere. If you've already gotten Taxotere as a chemotherapy, we cannot put patients on that trial, because you have to use it in combination of chemo. We cannot use the drug you've already received.
To what extent do UCLA cooperate with City of Hope at all?
We do, and actually, at a local level, things sometimes get a little bit competitive and contentious, but the reality is, at the institutional level, we all collaborate. So we have always I trained at USC, at City of Hope, at UCLA, and at Cedars, and I get regular updates on what trials are going on where. And we are always contacting each other, and sometimes it also is a question of who has slot open. For some of the newer drugs, there are a number of slots. You fill them up, you may have the trial going on, but you don't have an opening till you open more slots, but another institution may have slot open. So we all collaborate. There has been time when I've called City of Hope and I said, do you have a trial for my patient? And they said, oh, we sent our last 2 patients to UCLA for the trial. I said, yeah, but then you took away those slots, so I don't have those ones available. So at that level, we are all always sending patients to each other for the trials, because if we don't have the right trial for the patient, and we know the other institution has a better trial for the patient, we're always sending them back and forth.
Mm-hmm. You mentioned KRAS briefly, and I wasn't sure I caught whether you were talking about a targeted therapy or clinical trials, or both.
It's a targeted therapy in the form of a clinical trial.
And so there is a clinical trial for
Yes,
KRAS?
this was the,
Oh, okay.
I think it was one of the, let's see. I think it was a slide salute. I don't know how to pronounce that name either. I don't think I made a handout. I think, I can't read from there with the light going. Yes, clinical trial, it's number 27. I think this is the trial. This is the one which showed some of the data there. So there are.
How would I find that on clinicaltrials.gov? Just put in KRAS.
You're having a really hard time. Let me see. After the talk, we can go over. I have some of the lists of what we have right now available. Yes, KRAS, wild type only. Yes, there is a second line trial open for that at UCLA.
I'll catch you after. Yes, thank you.
Yes.
Yes. A person has COPD emphysema. Are they more at risk for getting lung cancer?
Not directly, but most of the patients who have COPD emphysema has history of smoking. And if you have a history of smoking, which was the cause of COPD emphysema, in that regard, there's a higher risk of lung cancer. And that's why they talk about screening for cancer in the patients.
Oh.
Yes.
Is any of this new form of therapy available outside of these institutions, like in an HMO?
Yes, but many of these drugs, I started off with some of the drugs that for the EGFR mutation. Those drugs have been approved long time ago. They are available everywhere, and they are used very early on in lung cancer if the tumor has it. Pretty much everybody checks the tumor at least for EGFR mutation and Alch mutation, and there are targeted drugs for those if the tumor markers are available. That's standard of care, and it will be done in all the institutions. And not just in US, they are used all over. In fact, with some of the early targeted drug with the EGFR mutation, they had more success in China and Japan than we had success here with some of the earlier drugs. There was an earlier drug that I remember that I participated in trial called Irissa was the brand name, and we didn't get very good responses in our Caucasian populations, but the Asian population was getting great responses. It has to do with how the pharmacokinetics are different in different ethnic populations sometime. And it wasn't that their tumors were more sensitive. It was the level of the drug that they were exposed to in those patient population was much better than in our patient population. We were seeing responses in the Asian populations, but we were not seeing responses in Caucasian population till Tarceva-like drugs became available, and once those drugs became available, they were not so sensitive to ethnic population in terms of getting enough drug level to get a response in the populations. So I think those drugs were approved, I think maybe 7-8 years ago. So they've been available everywhere.
The blood CEA marker, how useful is that?
Not very useful. In any cancer, there may be a tumor marker, there may not be a tumor marker. So what I do is early on, I check the marker. If it is elevated, it may be something can be followed for a response. If it is not elevated, then that's not an option. A lot of lung cancer do not make any marker. Some of the lung cancer will make CEA, but CEA is not specific to lung cancer. Colon cancer pretty much universally makes CEA, but CEA can be present in some of the other cancers also. Some of the insurances will not cover CEA for anything other than colon cancer.
What's the difference between PET and a CT scan?
PET scan is a scan which basically based on that the fast growing cells use more sugar, okay, compared to your regular cells, because the cancer cells grow fast, divide fast, therefore they use more sugar. So if a lymph node size is normal size, for example, the chest lymph node between 1 to 2 centimeter are normal size lymph nodes, but they can still have cancer. And a PET scan will show cancer as small as a 5 millimeter compared to a CAT scan, so it's a more sensitive scan. But as far as anything being more sensitive, you also get a little bit more false positive, because lymph nodes can be positive in a PET scan from infection also. Valley fever, which is very common in this area, will make lymph nodes PET positive, and even if they have a pneumonia, that will be PET positive too. TB does the same thing. A lot of other fungal infections will do the same thing. Sometimes patients will come in with a swollen lymph node, and you do a PET scan, it's hot, and they're worried the cancer is back, but that may be a sore throat or infection they had sometime.
That makes me think, does the cancer thrive on sugar?
Okay, all with the diet about no sugar diet, no, that's not. All cells thrive on sugar. But think of cancer cells as a parasite. You cannot eliminate all your sugar and kill the cancer cells, because the reality is everything we eat changes to sugar in our body. Oil, protein, everything changes to sugar, because the way every cell uses energy is by sugar. Now, cancer is like a parasite, so you cannot starve the cancer by eliminating all sugar. You will kill the patient before you'll kill the cancer. And even then the cancer will survive for a while, because that's how parasites work. So you need to really, you cannot starve them that way. You need to really see what makes them click, what drives these cancer cells, and go attack them at there.
What is the function of the office in Westlake Village?
It is a community-based practice. We work with the local physicians. Oncology office, when I joined UCLA, was mainly Dr. Slayman, who's the head of the oncology at UCLA. When he started with the translational research concept, he realized that most of the patients get treated in the community. So if you wait for the new drugs to be, I think it started with Herceptin for breast cancer. If you wait for these drugs to be tested only at big institutions, well, the big institutions really don't treat 20% of the cancer patients. 80% of the cancer patients are treated in the community. So you really need to move the trials to the community, because you can't make sick patients drive all the way, sit on 405 to get on a trial. So you need to really get the trials out in the community. And that was the basic idea behind UCLA Community-Based Research Network for Oncology.
How would one decide between a clinical trial of a targeted drug such as Tarceva or one of the newer ones?
No, Tarceva is not in trial. It's been available a long time. Yeah, no, that's fine. Yeah.
But versus immunotherapy.
Okay. So immunotherapy, the PD-1 and PD-L1, they're not available to everybody. The tumor has to express that. That's the first step. Okay.
I'm sorry, it has to express.
PD-1. So the tumor has to be analyzed for it. Okay, so it's
PD-1
expression, yeah. So that's the first thing. Now realize that in any of the trials, the general concept is, in terms of the targeted drugs, patients will get standard drug plus minus the targeted drug many times. So it's not that patient will not get any standard drug at all. So everybody will get something, plus minus the other thing. Now the immune therapies are a little bit different, because you can't usually combine them with chemotherapies, because you're trying to stimulate your immune system to attack. So those are usually being used, when you're using that, you know very quickly whether the patient is responding. That's the beauty of some of these things. You know very quickly whether the patient is responding or not. If the patient is not responding, first you analyze the tumor to see which patient is going to respond, which, based on the earlier data we have, and then you analyze. Most of the trials require a scan at 6 weeks. So you know within 6 weeks whether the drug is working or not. If the drug is not working, you move on. You move on to another trial, or you move on to the standard drug. So you don't lose anything by going that. But if you have had 4 series of different kind of treatments, you may not be candidate for some of the earlier trials. There may be still trial available, but the options may be different.
The target therapy doesn't work, and chemotherapy also doesn't work. What else?
So as we talked about, there may be different targeted drugs that may be option, and immunotherapies may be an option.
You said getting a biopsy can be uncomfortable. Where would you go for the tissue?
In any patient, we look at where all the tumor is and what is the easiest and the safest place to go for the biopsy. So there is not a general statement. You had a question?
Oh, are you seeing a rise in lung cancer in non-smokers?
It feels like it. It does feel like it.
Is there research on what's going on with that? And
I've not come across any research about it, but it does seem like there is an increased incidence. Some of it may have to do with a better analysis. Okay? What I mean by that, adeno-CA, which is the most common non-smoker lung cancer and seems to be the most common cancer, adeno-CA just means the cancer arose from a gland-like cells. All breast cancers are mostly adenocancers. Colon cancer is adenocancer. Stomach cancer is adenocancer. Majority of the cancer are adenocancers. So if you see cancer in the lung, it is possible that one may get labeled as metastatic cancer of unknown primary, or assume that it is a cancer which has traveled from somewhere else, because many of those non-smoker lung cancers also show up like multiple spots in both the lung, something we think about as cancer spread from somewhere else. And some of may have been also lack of the proper diagnosis in the past. But it does seem like there is no reports about increased non-smoker lung cancer. Smoker lung cancer has gone down, but it does seem like the non-smoker lung cancer is on the rise, yes.
What is the incidence of a genetic link for the non-smoking adenocarcinoma?
There is no genetics that we understand or know of as a risk factor for a non-smoker lung cancer. not that we know of. So the cancer syndromes that we are aware of, we know of a linkage with the colon cancer, we know of linkage with the ovarian cancer, uterine cancer, breast cancer, sometimes GI cancers of other kind also, but so far we have not identified anything that drives the lung cancer. We do know that certain patients may process toxins differently than the other patients. So whether it comes to the risk of smoking-induced cancers or cancers being induced by different toxins. So some populations may be more sensitive. That's one of the reasons we talk about women being more sensitive to smoking causing lung cancer. For the same reason, because women's sizes are sometimes small, we clear up drugs in a different ways sometimes, and that may be the reason that women exposed to toxins or smoking will develop lung cancer more easily than men. If there is the same amount of smoking in men compared to women, more women will develop lung cancer. And that's why when women equality meant that more women will be smoking, that was not necessarily a good sign. But we are finally beginning to see a decline. We actually saw more decline in men than we saw in women. Because I think women were a little late to catch up on smoking, will be probably a little late to catch up on quitting smoking. Yes?
I was just thinking about other people. How early could you diagnose the cancer, and what would be the type of?
So the screening for lung cancer is only recommended in the high-risk smoker group. What I mean is what they call 30-pack year history, and they have quit no more than 15 years before. And so for those patients, they recommend low-dose, non-contrast screening CAT scan. So because you don't want to expose patient to a whole lot of radiation. So this is low dose without contrast, so it's labeled as that. So the exposure is less than the regular CAT scan and no contrast is given. That's the only modality that has shown to diagnose lung cancer early enough to make more patients survive, and actually the studies has shown a 20% improvement. But it is still being debated because in terms of health dollars, it's still a lot of money doing a CAT scan on all smoking patients or patients with history of smoking every 3 years. So it's still being debated, but it is approved and it should be covered at this point. Although at some level, as seems like more and more emphasis is don't do as many mammograms, don't do as many pap smear, don't check PSA. We seem to be, some of the data is going backward, and so I think it's also a question of rational. Lung cancer to a degree has not been treated fairly to a degree because it's been always labeled as a disease of the smoker. So, there has been sometimes people saying, oh, they brought it on to themselves, so why should we be doing that? And that's not the right way of looking at it. The reality is in this state, we all smoking. You drive by on the 405, you're all getting exposed to the smoke. There's nobody away from the smoke and the pollution now. And that's not the reason not to screen somebody. In the past, we did not have effective drugs. So finding things early didn't really make a difference. Now that we have more effective drugs, it does make sense to do that. So the earliest stage is, of course, stage 1. But most of the non-smoker cancers do not get diagnosed at stage 1 because they're not looking for it. And in fact, they are many times pretty late in being diagnosed because, somebody non-smoker has a cough, the doctors are usually not going to recommend getting a CAT scan or a chest X-ray easily because, none of us want to believe that that person is the unlucky patient where it's really not a bronchitis and really a cancer. Yes.
If one were on a clinical trial out of UCLA, number one, do you have an infusion center in Westlake? Here, okay. Could one have their infusion in Ventura?
Ventura, we do not have an office in Ventura.
Okay, it has to be the office of the facility that's
where the trial is. UCLA does have some research linkage with the Ventura oncology group there. They have some trial. The big group in Ventura? They do have some trials. They're not directly part of UCLA. There are there are certain, like our office is really a UCLA health group, but there is also something called UCLA Tori Network where the offices are independently owned, but they have some of the research trials of the UCLA. Not all of them. And even here, we don't have all the trials locally because there are certain trials which require a little bit different processing of specimen. Exactly. And this office is still gaining space and expanding. It does require a lot of other processing and things, so as it expands, yeah. Yes, more and more trials we are adding up. We are 5 doctors in this office, so, so yeah. So, there are multiple trials that are becoming.
I drive all the way to City of Hope every
Yeah,
3 weeks.
yeah. That's the thing, and that's the thing, and especially with some of these newer drugs, if you feel well enough that you can actually drive down, not that you want to spend your time doing that. And that's one of the beauty about these new drugs. A lot of these drugs are not toxic like our old chemotherapies, so a patient can function like a normal person.
Maybe you could take them at home like Tarceva.
There are a lot of drugs, well, a lot of new drugs are being oral drugs also. A lot of new targeted drugs are oral drugs, not injectables even.
So you see things changing pretty rapidly.
Very rapidly, and not just lung cancer, but all over the place. I mean, nowadays it's like we're using one, the mTOR, one of the target I talked about. We are using mTOR drugs for kidney cancer now, and we started using some of them for liver cancer, and now we are finding targets in some of the lung cancer. So where I see for all cancer, eventually it will be you take the piece of the tumor, you analyze for gene profile, and you say, okay, 1, 2, 3, 4, these are the drugs that will work for this tumor, and we, based on the understanding at that level, then we use those drugs.
So speaking of data collection, and tumor analysis, is it automatic when a tumor is removed? Does pathology automatically do that? So
No.
how are you collecting the data?
Those are patients' volunteered tumor pieces.
Oh, okay.
Okay, they're volunteered by the patient. Okay, a lot of these testing, fortunately, can be done in the stored tissues. Okay, so the most of the time, there's certain testing that cannot be, but more and more of testing can be done in the tissue which is already preserved. And pathology never throws away the tissue. They will get the testing, they'll give us the tissue for testing as long as they have any tissue left. And so everybody who has adenoCA lung in advanced stage, their tumor, most of the doctors their oncologists will order EGFR and Alch testing. And then beyond that, outside of the trials also to see which one, there are certain companies which offer, where they do a whole panel, they do EGFR, Alch, but they also do a whole panel of other things. And then there is only testing like for PD-1 that's done strictly for the trial. It's not tested otherwise. But most of these testing can be done on the preserved specimen. Usually pathologists are pretty good about using the specimen they have very judiciously.
So that I understand the PD-1, if one were to want to go on a trial, then the tissue would have to be retested just for PD-1? Okay.
Yeah. And I think the trial is available at City of Hope also.
Yeah, okay.
But different ones keep opening and closing for different group of patients, yeah.
Thank you.
Any other question? Thank you. You guys are very involved. Thank you.